As I said, I'm Dr. Kevin Cope. I'm the medical director of Mountain Valley Hospice and Palliative Care. And we are recording this for people that weren't able to make it online today. So welcome. And we're going to take about a half an hour, and we're going to be talking about evaluating and treating constipation in patients with serious illness. And some other people also may hop on and join us. So I want to talk a little bit about our, just a reminder about our program. We are a we offer a home-based palliative care program. Our program helps your patients get symptom relief from their serious illnesses at home. We also, I might add, explore patient wishes for how aggressive they want their treatment to be in the future. And one of the benefits of our home-based palliative care program is we connect to a nurse with a provider online who can actually go through the whole MOLST form if needed and sign those forms. And so that's often very labor-intensive process with the patient to discuss their end-of-life issues, and we can do that through our palliative care program because I know it's often hard to squeeze that into an office visit. So I just want to remind people about that it is helpful that way. So and then we offer hospice care, and hospice care is for patients that during the normal course of their disease have less than a 6-month prognosis. And we're still trying to get people referred to our hospice program earlier because the statistics show that actually over 50% of people admitted to hospice actually pass within the first 30 days, and about 10% actually pass within the first 3 days. And the hospice benefit is for 6 months, and we have all kinds of services to help people with hospice care, and we want people to be able to take advantage of that. I wanted to discuss a quick case history here. John is an 82-year-old male with a history of osteoarthritis and slowly progressive dementia over the last 5 years. Last night, he had lots of trouble sleeping and was very agitated and moaning and grimacing. So throw this out there. Which one of the following may be causing John's agitation, moaning, and grimacing? And I got urinary retention, certainly in a male, an elderly male. That's something that needs to be considered. Infections such as a UTI, certainly a possibility. Pain itself might be causing his symptoms, his agitation, his moaning and grimacing, and constipation, which is often an overlooked one, can also be causing John's agitation, moaning, and grimacing. And with his cognitive impairment, he's really not able to verbalize that. So really, when you have a patient that seems uncomfortable, agitated, having trouble at night, think of these 4 possibilities with any patient: urinary retention, infection, pain, or constipation. And constipation is one of the most common distressing symptoms experienced by patients with serious illness. It occurs in at least 70% of patients with serious or chronic illness, and it often goes unrecognized and undertreated. And even the term constipation can mean a lot of different things to a lot of people. Here's a question. The term constipation can mean which of the following? Number 1, stools are too hard or too small. Number 2, defecation is too difficult. Number 3, defecation is too infrequent. Or 4, decrease in normal bowel movement pattern. And the answer is all of the above. And there's really no nationally, universally recognized definition of constipation. So it often leads to, there's often some misunderstanding about it, and it's often goes underdiagnosed. And so we want to talk about that this afternoon because constipation is very preventable and treatable. And it can significantly diminish the quality of life, increase stress and costs for the family caregivers, and result in preventable complications, emergency department visits, hospitalizations, and even death from colonic perforation. So it's a serious condition, but it's also very preventable and treatable. And so in our case, this 82-year-old male we talked about with osteoarthritis and cognitive impairment, advancing dementia, which of the following may be contributing to his constipation? And really, it can be any number of these: reduced food or fiber intake, reduced fluid intake, age itself is a risk factor for constipation, decreased mobility, he's not getting around like he was, pain in itself and the treatments for pain can certainly lead to constipation, which we'll talk more about. So it's really all of the above. And if you think of some of the contributing factors that might be causing John's constipation, think of an independent male who's been using the toilet independently, and that's a very independent process. And now with his dementia, there's a lack of privacy and comfort. He doesn't like to be assisted with toileting, so maybe he doesn't want to go. There's a lack of privacy there, and that's very troublesome to him. He may not be able to verbalize that. A lot of people have trouble going using a bedpan or commode. They're just not comfortable going that way, so they tend to avoid it. Or maybe his inability to get to the bathroom. There might be a mobility issue on this 80-something-year-old gentleman that we're talking about. And age itself can be contributing to his constipation. So think about some of those factors. The other thing you need to think about is the medications that John might be on. And a lot of these medications can actually be obtained over the counter by families and patients, and they may not even consider that a medication. They may not even mention it to the provider. So it's very important to get a good history of what the person is actually taking or what the family members are actually giving the person. So here's kind of a list. Opioids certainly are high on the list, and that's very expected and preventable. And we're going to talk more specifically about how to treat constipation from opioids. Anticholinergics, amitriptyline is a well-known one, but think about also there's diphenhydramine, Benadryl, which is over the counter, can cause constipation. Oxybutynin, given for urinary problems. Then antacids, again, another over-the-counter medication. Anticonvulsants, calcium channel blockers. Sometimes that's overlooked, but think about a calcium channel blocker has the effect of relaxing smooth muscle on the blood vessels. It also relaxes the muscles, the smooth muscle in the intestines, and can definitely lead to constipation. Antiemetics, antitussives, antidiarrheals, antiparkinsonians, neuroleptics, antidepressants, iron and calcium, again, two over-the-counter medications that are often taken by patients, diuretics, and chemotherapy. So I think it's important to do a good medication history when you're assessing constipation in a patient, including the over-the-counter medications they're taking. And the other thing to remember, and this is why it often goes unrecognized and undertreated, is that in most patients with constipation, their vital signs and their physical exam are normal. The other reminder I like to throw out there is when assessing the symptoms, recognize that constipation may actually lead to paradoxical or overflow diarrhea with leakage of fluid feces around an impacted stool. So the patient may be saying, the family's complaining that they're having diarrhea, but really what they are is constipated, because that's an overflow diarrhea that's leaking around an impacted stool. So one of the things you want to think about is fecal impaction when somebody is constipated, and this can be confirmed by rectal exam or a simple abdominal flat plate x-ray, very inexpensive. And you want to, if there is evidence of fecal impaction, you want to use something like a warm water enema and possibly manual disimpaction before giving the laxatives if the patient has a significant fecal impaction. The other thing you want to think about in this area is, could the patient be developing a bowel obstruction? So if there's nausea and vomiting and constipation, then you're going to have to think about a bowel obstruction. And if you suspect this, you should get a CT scan to rule out a mass, adhesions, or a volvulus. So let's talk a few minutes about treatment of constipation. There's non-pharmacological interventions that can be done and pharmacological interventions. So some of the non-pharmacological interventions are to optimize toileting, make sure that person does have a place where they feel comfortable, that they can go, increase their fiber intake, increase fluid intake, improve mobility. Just getting a person up walking will often help relieve constipation. And as we mentioned, review medications and prunes. It's that age-old treatment for constipation, and prunes actually have been proven to work not just beyond the fiber that's in them. Prunes actually have a high content of sorbitol in them, and that causes they act as osmotic laxatives. They actually draw fluid from the surrounding tissues into the colon, and definitely can be very effective in treating constipation. And then there's the pharmacological treatments, and often they are needed to treat constipation, serious cases of constipation. So don't be afraid to use pharmacological treatments, especially on patients on opioids, which we'll talk about. But really, patients on opioids should be on prophylactic daily laxative therapy to prevent constipation. So there's two main types of laxatives. There's the osmotic ones, similar to the prunes, that work by drawing water into the colon from surrounding tissues. And then there's the stimulant laxatives that trigger the intestines to contract and push out stool. Examples of the osmotic laxatives are the polyethylene glycol products. Brand name is Miralax. Lactulose syrup is also a good osmotic laxative. We use a lot of lactulose because it can be titrated up until you get the desired effect. Some people don't like they feel it causes some excessive gas, but it's inexpensive. But Miralax is also a good alternative for if gas is a problem from the lactulose. These can be used daily, and they do not cause a laxative dependence. So they're very beneficial in people with chronic constipation. Milk of magnesia and magnesium citrate are okay to use for occasional use, but you've got to remember that a lot of the elderly patients have renal insufficiency, and you got to be very careful about giving magnesium to a patient with renal insufficiency, because that can build up. They don't eliminate it. It can cause arrhythmias, and so be careful about that. That's contraindicated in patients with renal insufficiency. The other thing that, again, is an over-the-counter product, and all of these listed here are, so you got to make sure your patients aren't using these without telling you, especially those ones with renal insufficiency. But a Fleet's enema, which has phosphate in it, can again build up in somebody with renal insufficiency and cause some serious cardiac arrhythmias and problems that way. So the stimulant laxatives are mainly the bisacodyl and the Senna products. So bisacodyl is a brand name Dulcolax. You could get it in tablets or suppository. Senna is very popular and common, and Senecot is a brand name. Some of the old-fashioned laxatives, like the X-Lax products, those are mainly made with Senna. They're stimulants, and you have to be a little careful with those because they can lead to dependence. But you have to weigh the risks and benefits of it, and oftentimes they are needed. And I know in palliative care and hospice care, we have a lot of patients on daily Senna, which is very beneficial for them. So they will often need a stimulant laxative along with an osmotic laxative. So let's talk in a few remaining minutes here about opioids and constipation. The constipating effect of opioids is predominantly mediated by binding of opioids to the mu receptor in the GI tract. This reduces GI motility and inhibits fluid secretion into the intestinal lumen, causing delayed colonic transit and dry, hard stools. And unlike other areas of opioid where patients develop tolerance to them, tolerance to constipation never occurs from opioids. So unfortunately, the GI tract does not get used to the opioids on board. So they definitely cause significant constipating effect on the GI tract because of binding to those mu receptors. So when you think about this, think about some treatments. It would be nice to recommend Colay stool softeners, Docosate, but for opioid-related constipation, it really has not been shown to demonstrate efficacy. As well as the bulk-forming laxatives, the things like sililium or fiber like Metamucil can actually worsen constipation because some of these patients are not taking enough fluid intake, and the excess fiber can actually worsen the constipation. So most guidelines do not recommend them for opioid-induced constipation. So what is recommended? For opioid-induced constipation, you really want to use a combination of the osmotic and the stimulant laxatives that we've talked about. Things like the Miralax, the lactulose as osmotic laxative in combination with the stimulant laxatives, things like Senna. And in most cases, you can treat opioid-induced constipation with a combination of those osmotic and stimulant laxatives. And the nice part about those is they're readily available, they're very inexpensive, they've been around forever, and they're generic products and usually cost less than $10 a month to treat that opioid-induced constipation. Now, there are some resistant cases, and the drug companies have certainly found a niche with this, developing drugs to treat opioid-induced constipation. And you can use these, but in real resistant cases, but realize that they are very expensive and try and avoid them. So, for example, I looked up the prices last night of some of the prescription drugs available for opioid-induced constipation. The naloxone, brand name Movantik, is $400 a month, and this is on GoodRx. Lubiprostone, which is Ametizia, is $200 a month. Methyl naltrexone, which is Relistar, is $2,000 a month, and now Dimidine Simproic is $350 a month. So these brand name products, which have been marketed by the drug companies specific for opioid-induced constipation, are very expensive, and we try and avoid them if possible. So just want to give you a couple of key takeaways then from this. To remember as you're working with your patients, with people in the community that you take care of. Constipation is a common symptom for persons with serious illness and is associated with significant morbidity. So don't forget about that person and treating constipation as a possible symptom for even for those that can't verbalize it, for the agitation, for the moaning, the grimacing. Don't forget about constipation as a possible cause. Constipation has a profound adverse impact on quality of life for patients and families, so it should be aggressively prevented and treated. All patients with serious illness should be educated on using non-pharmacologic methods of preventing constipation. And if constipation does not respond to the non-pharmacological measures, use one or a combination of osmotic and stimulant laxatives. Consider fecal impaction or bowel obstruction before giving laxatives from above. So if there is a suspicion of that, investigate that further. And in opioid-induced constipation, a consistent and closely monitored bowel regimen is essential, including osmotic and stimulant laxatives. So I just wanted to thank you, and we try and do these once a month, talk about some of the conditions we treat all day long in palliative care and hospice care, and give you some advice for treating people in the community that you take care of. So thanks for your attention. We'll have our next town hall Wednesday, October 26th, 12:30 to 1. We'll talk about nausea and vomiting in patients with serious illness. Please feel free to email me with any questions with our palliative care program or hospice care program or anything from today. You could also leave comments in the chat if you'd like. And I will email around the recording of this and the PowerPoint. So thanks. Thanks also to the Center for to Advance Palliative Care for their input on this topic, as I found a lot of their information very helpful.